Welcome, everyone, to this AC Forum webinar titled Under-prescribing of Oral Anticoagulation and Associated Outcomes for Patients with Atrial Fibrillation, a call to action. Next slide. Our presenters today, I want to introduce you to some fabulous colleagues of mine. First, Julia Mulheman, who is a pharmacy manager with the Cleveland Clinic Health System. And Naomi Yates, who is a clinical pharmacy services manager for anticoagulation services in Kaiser Permanente, Georgia. And then I'm Sara Vazquez. I'm a clinical pharmacist with the University of Utah. Our disclosures and notification of support, none other than I am a consultant for UpToDate for warfarin topics, and that is not relevant to today's topic. You may claim CE credit for this webinar, and we have listed the website on the slide, and we'll put that in the chat as well. And you follow the instructions there to claim your credit. And just to note, this is also eligible for 1 hour credit of medical ethics or professional responsibility CE. And just as a note, both Julie, Naomi, and myself are members of the IDEA initiative for AC Forum, which is inclusion, diversity, equity, and allyship. And our goals for this initiative, we're about 2 years into this initiative, and we are continuing to pursue and push forward these goals. And this webinar in particular focuses on our goal of increasing awareness of structural racism and its impacts on health inequities and disparities. And if you want to learn more about the IDEA initiative, you can see the website on the slide, and we'll put that in the chat as well. If you want to join us in this initiative, we would love to have you and encourage you to contact info@acforum.org. And now I will turn it over to Julie.
Thank you so much, Sara, for the introduction on this webinar. And good afternoon to everybody. Thank you for joining on to the webinar today for this very necessary and important topic. We thought we would start this off by presenting 2 case scenarios. These are both very realistic patients that we may have all seen within our own clinics. One case represents the appropriate care that everyone needs and deserves, while the other allows a look into how disparities in healthcare can occur. Then at the end of this presentation, we will come back and circle back to these cases to provide some thoughts around what could have gone better. Our first patient here is BL. He is a 67-year-old white male CEO of a marketing company. His past medical history includes hypertension and diabetes. He presents to his PCP office for a yearly wellness physical and is found to have a heart rate of 120 beats per minute with irregular rhythm. His medications currently are lisinopril hydrochlorothiazide 10 per 12.5 milligrams daily, atenolol 50 milligrams daily, and metformin 500 milligrams BID. Most recently, he has been very fatigued and short of breath. Some other physical exam findings are here below and all normal. An electrocardiogram is performed, which shows that he is in atrial fibrillation with a rapid ventricular response. BL's CHADS 2 VASC score is 3. Our next patient is JJ. JJ is a 78-year-old Black male taxi driver. His past medical history is hypertension, and he is mildly overweight. He was admitted to the hospital with pneumonia, and upon admission is also found to be in AFib. His current medication is lisinopril 10 milligrams daily. He is consistently eating in his car and therefore picks up quick and unhealthy foods to eat. In the first case here, there is shared decision-making between BL, the patient, and his medical provider. They decide to put him on apixaban 5 milligrams BID. BL is given a copay card, and he goes to the pharmacy to pick up, and he starts his medication right away with a follow-up appointment in 6 months with his PCP. JJ is discharged on day 5 after recovering from pneumonia on the same medication he was previously taking, which was lisinopril, along with a prescription being sent to his pharmacy for warfarin. JJ was told to take 5 milligrams of warfarin daily, and he would receive a call from a monitoring clinic in the next 1 to 2 days. JJ came back to the ER 10 days later with severe abdominal pain and black stool. Atrial fibrillation has been called an emerging cardiovascular epidemic. It is the most common arrhythmia, with up to 60 million adults impacted worldwide. AFib increases cardiovascular morbidity, including ischemic stroke. It also increases mortality risk, resulting in about 158,000 deaths each year in the United States alone. These deaths related to AFib appear to be on the rise, and one concerning point is that it is particularly found among younger adults to be on the rise. According to an article within the Journal of American Heart Association in 2021, the authors in this article hypothesized that the growing burden of risk factors such as obesity, hypertension, and diabetes in these younger adults is likely driving this greater proportion for the changing burden of AFib mortality. It is important not just to think about this increase in prevalence of AFib, but also to think about how it then increases the overall economic burden of AFib. To better talk through this, I have broken it up into some different categories here. First, I wanted to talk about the total costs of AFib care in the United States. You can see here it's approximately $6.65 billion per year, and that's per the 2005 dollar value. But what makes up those total costs for the AFib care? We have direct costs and we have indirect costs associated. The direct costs are those payments both from the insurers and the patients, such as copays for office visits, copays for the medications that are used to treat AFib, whether it's the rate and rhythm controlled meds or the anticoagulants themselves. And then there's also costs related to different procedures or interventions that can be used in the treatment of AFib. And then we also have these indirect costs that are greatly associated with hospitalizations, whether it's due to bleeding complications or thrombotic complications. And you can see here that those indirect costs make up a great proportion, approximately 75%. Now, we know that AFib may be asymptomatic or paroxysmal or otherwise clinically silent, and then therefore could go undiagnosed. There is also a total cost that is linked to this undiagnosed AFib, which is around $3.1 billion. What we can state is that if we can come up with some strategies to identify and treat this undiagnosed AFib, we could then have a much sizable reduction in the stroke and associated costs with that. In the final bucket here, we wanted to bring attention to the cost of ethno-racial disparities. It's important to note here that this is all of the healthcare disparities within the ethno-racial population, not just with AFib, but we still wanted to definitely mention it. It's around approximately $1.24 trillion. It's also important to note that the Institute of Medicine defines a disparity as a difference in treatment provided to members of different racial or ethnic groups that is not justified by the underlying health conditions or treatment preferences of patients. So we know again that AFib continues to increase in prevalence. We know that it is the most common arrhythmia. However, why is there such limited AFib data in certain populations listed here? Black, American Indian, or Alaska Native, Native Hawaiian, or other Pacific Islander populations. Why is this true? There are some different reasons that we can go through, one being differences in study design. It is known that Black patients specifically are represented only as a very small proportion in AFib clinical trials. Because safety and efficacy may vary in different populations, the lack of this racial and ethnic diversity in clinical trials compromises the healthcare that can be delivered to those who are excluded. Another reason could be access to care or lack thereof. When there is limited access to care, there will therefore be limited detection in AFib, along with limited treatment of AFib, and therefore limited data that can be used. Finally, another reason for this limited AFib data in these populations are the AFib detection methods. There needs to be better monitoring available in more diverse samples of patients in order to gather a better understanding of why Black individuals have a lower reported prevalence of AFib compared to white individuals. Which brings us to this next slide here. It is known that Black individuals have this lower incidence and prevalence of AFib than white individuals. But traditional AFib risk factors are more frequently found in Black individuals. This in itself is known as the atrial fibrillation racial paradox. This is basically where, for example, a lack of access in care meets an increase of these traditional AFib risk factors or other comorbidities, then is also met with an under-prescribing of anticoagulation, which ultimately leads to worse outcomes in Black individuals with AFib. The paradox is then the pondering of why all of this above information is so, even though AFib is not as prevalent in the Black population. What is the cause of the racial paradox? And honestly, it cannot be definitely linked to one reason, and there is only some speculation around it. But here are some thoughts. One potential reason could be the ascertainment bias, which basically some members of a target population are less likely to be included in final results. This bias could also be related to diminished access to healthcare. Another potential reason could be survival bias. It is known that the white population has a longer life expectancy and therefore may have an increased risk of AFib over their lifetime. Finally, the paroxysmal nature of AFib, along with some reduced sensitivity of electrocardiogram screening, may also result in under-detection. A study that helps to explain this somewhat is the MESA study, the multi-ethnic study of atherosclerosis. Initially, it looked at 6,800 Americans that were free of clinically recognized cardiovascular diseases between the timeframe of 2000 and 2002. Then there was a 14-year follow-up, and during 2016 to 2018, there were 1,556 individuals that were pulled for an ancillary study, which involved ambulatory ECG monitoring, and then those patients had follow-up for clinically detected AFib. Among the 1,556 patients, 41% were white, 25% were African American, 21% Hispanic, and 14% Chinese. In this 14-year follow-up, AFib was clinically diagnosed more often in white individuals, you can see the percentage here, than in those who were African American, along with the percentage there, and this is significantly lower. However, in contrast, that same group of patients were screened with a 144-day continuous electrocardiogram monitor, and the proportion of monitored detected AFib did not differ significantly by race or ethnicity. This is an example of a population study that showed Black individuals to have a lower incidence and prevalence of AFib compared to white individuals. And again, it shows an example of this racial paradox. Oral anticoagulation is the optimal choice of antithrombotic therapy for patients with atrial fibrillation with greater than or equal to 1 non-sex CHADS2 VASC stroke risk factor. We wanted to show here that 3 of these guidelines either had strong recommendation or a class 1 recommendation, but they all recommend using DOACs over warfarin for those who are eligible for oral anticoagulation.
Thank you, Julie, for sharing with us guideline recommendations for oral anticoagulant use in AFib. Unfortunately, studies have demonstrated that these guideline recommendations are not being applied to all patients equitably. As you can see here, warfarin is less likely to be initiated in Black individuals when compared with white individuals. Also, Black individuals are less likely to receive a prescription for a direct-acting oral anticoagulant. They're less likely to fill a prescription for warfarin upon discharge, and they have a lower time in therapeutic range. The Get With the Guidelines AFib registry uses quality measures to attempt to improve the care of patients with AFib. Researchers propose that the reasons behind the disparities in oral anticoagulant prescribing are multifactorial. The first possible explanation is socioeconomic status. Providers may be overestimating risk for patients from specific racial and ethnic minority groups based on preconceived notions of the patient's socioeconomic status. It has been noted that oral anticoagulants are less prescribed for patients with end-stage kidney disease, low income level, and for those with greater distance to care. It has also been demonstrated that some providers perceive that persons of color are less intelligent and may not adhere to the regimen. Reduced access to care, either by distance to a quality provider or through poor insurance access, could also limit oral anticoagulant prescribing. Perceived or actual financial limitations could be contributing, and then inadequate follow-up by healthcare providers. Of note, this could also explain the lower rates of post-discharge adherence. In addition to pharmacological interventions, disparities also exist in non-pharmacological interventions. Non-white individuals are underrepresented in clinical trials of catheter ablation and left atrial appendage occlusion. They have lower utilization of procedural rhythm control strategies such as cardioversion, ablation, and left atrial appendage occlusion. And they're less frequently referred to electrophysiology subspecialists. We also observe disparities in clinical trial representation, as Julie mentioned. Though approximately 14% of the United States population is Black, Black patients comprise less than 2% of the study populations in our AFib clinical trials comparing DOACs to warfarin. In fact, most clinical trials of cardiovascular disease and arrhythmia predominantly enroll white individuals and have lower enrollment of African Americans, Alaska Native, Hawaiian Pacific Islander, and some Asian populations. Frequently, these clinical trial results are extrapolated to the general population, but we don't really know how generalizable these results are to racial and ethnic minorities. Due to the poor enrollment of minorities and women in clinical trials, the National Institutes of Health Revitalization Act of 1993 was enacted. This act directed the NIH to establish guidelines for inclusion of women and racial and ethnic minorities in clinical research. And though we have seen major improvements over time, significant inequities in racial and ethnic diversity remain for NIH-funded cardiovascular studies. There are several contributing factors. Research atrocities against racial and ethnic minorities, to name one, lack of community and patient engagement. There are system barriers, for example, health insurance is often required for clinical trial participation. They typically have arduous consenting processes and inflexible research protocols that do not take into account real-life experiences and priorities of many potential research participants. And then centuries of discrimination and segregation, forced unconsented medical research, and denial of access to care have led to distrust in the medical system. To provide one example of why some communities might distrust the medical system, we would like to bring your attention to a study referred to as the Tuskegee experiments. This was a study conducted by our United States Public Health Service with the Tuskegee Institute, beginning in 1932 and ending 40 years later in 1972. This was a study in 600 Black men, some with syphilis and some without. And the purpose of the study was to observe the outcomes of patients with syphilis when left untreated. They encouraged patient enrollment under the guise that they would receive free meals, free transportation, and burial insurance. Though in the mid-1940s, penicillin emerged as the treatment of choice for syphilis, treatment was withheld from study participants. When left untreated, syphilis can cause permanent organ damage, paralysis, blindness, severe mental illness, and death. So the resulting trauma is that today, many Black communities do not trust the healthcare system. These disparities in research, access, and treatment have resulted in disparities in outcomes. Black individuals with AFib have a twofold increased risk of ischemic stroke when compared with white individuals. The association of race and ethnicity with oral anticoagulation and associated outcomes in patients with AFib study was a retrospective cohort analysis conducted examining outcomes in patients from the Get With the Guidelines in AFib registry. Prior to this analysis, it was well known that oral anticoagulants were prescribed at a lower rate in persons from underrepresented racial and ethnic minority groups. What was not known was whether there was any correlation of this underprescribing and AFib-related outcomes. So the results were that among 69,553 individuals hospitalized with AFib, the one-year cumulative stroke incidence was 1.9% overall. And then when we look at our Black population compared with our white population, we can see that this is where we have this twofold increased incidence of stroke at 3.8% in our Black patients, followed by 3.3% in our Hispanic population and 1.7% in our white patients. It was also observed that there was a higher incidence of stroke in Black patients discharged while taking a direct-acting oral anticoagulant, and a higher incidence of stroke in Hispanic patients discharged without any oral anticoagulant. When we examine the bleeding and mortality rates, we do see something similar. The 1-year cumulative incidence of major bleeding was 5.5% overall. But again, we see this twofold increased risk in our Black patients compared to our white patients. So in our Black population, the incidence was 11.3%, followed by our Hispanic patients at 6.7%, and our white patients at 5.3%. The 1-year cumulative incidence of mortality was 16%. And again, the mortality risk was highest in our Black patients, then Hispanic, then Asian, and then our white patients. Of note also is that our Black patients discharged without any oral anticoagulant had significantly higher rates of mortality than their white counterparts. Knowing that these disparities so severely impact outcomes necessitates a call to action. What can we do? It will take population-based efforts as well as individual efforts. Population-based efforts such as policy changes, private-public partnerships, and a commitment to allocate resources to address the downstream impact of social determinants of health on health outcomes. We need to recognize and provide training around implicit bias and cultural humility, understand structural racism and how it can lead to health disparities, diversify the healthcare workforce. It's okay if a patient feels more comfortable with a provider who speaks their native language. And we need to advocate and collaborate. We would like to call your attention to a couple of resources that are available. The first is the AFib Better Care Pathway. The A stands for avoiding stroke. So the first thing to do is assess the patient's thrombotic and bleeding risks, and then have a shared decision-making conversation with that patient and their caregiver to determine first if anticoagulation is the best option for the patient. And then second, what anticoagulant medication is the best option for the patient. B stands for better symptom control. We want to focus on rate versus rhythm control in these patients. And then C stands for cardiovascular and other more comorbidities. We want to try to address the other comorbidities that could be impacting this patient's AFib care as well. So we want to try to manage hypertension, heart failure, diabetes, cardiac ischemia, sleep apnea, and I mentioned as well lifestyle factors such as obesity and excess alcohol. I would add in also smoking cessation where applicable. Through applying the ABC pathway to all patients, this can help us limit any implicit biases we as clinicians may have. And then we wanted to draw your attention to the Social Determinants of Health Rapid Resource that is available now on the AC Forum Center of Excellence Resource Center. The first page explains various social determinants of health that can affect patient quality of life, such as community engagement and food insecurity. And then the second page is a quick one-page checklist that you can actually use when in the office or on the phone with a patient. It provides suggestions on steps you can take to address the various social determinants of health. This brings us back to our cases. So in case scenario 1, VL is seen for his 6-month follow-up visit. We can see in this case is that there are multiple disparities at play here. VL is able to come in for his 6-month follow-up visit. If you remember in the beginning, he was seen for his yearly wellness physical, and this is how the AFib was detected to begin with. He and his provider had a shared decision-making conversation to determine if anticoagulation was the best option for him, and then which anticoagulant medication would be best. And ultimately, they decided on a direct-acting oral anticoagulant. The patient was adherent to his medications and his office visit. With case scenario 2, JJ, he's now admitted to the hospital due to bleeding as a complication from the warfarin. His INR was above 8 on admission. He was not aware of how often he needed to follow up while taking the warfarin, so he did not call the monitoring clinic right back. So we can see in case 2 that warfarin was prescribed without any shared decision-making conversation. The provider may have looked at the patient and, due to implicit bias, assumed that the patient could not afford a DOAC. JJ is a truck driver, so we don't know if he would have been able to come in for his INR monitoring, and this was not discussed at his office visit. The monitoring clinic did call once to attempt to outreach to the patient, but they did not follow up after that. And then the provider also did not follow up to ensure the patient was able to obtain the medication okay and connect with the monitoring service. If the ABC pathway had been followed in both of these scenarios through having a shared decision-making conversation with both patients and their caregivers to select the best anticoagulant therapy for each patient, addressing rate and rhythm control and cardiovascular risk factors as well, we could have ensured that we were providing the most optimal care for each patient's unique scenario.
Thank you so much, Julie and Naomi, for reviewing those statistics and that literature and those data for us on this topic. I would encourage the audience to please type your questions into the Q&A box that I will pose to Julie and Naomi. And while you guys are doing that, I just wanted to address a comment that came in from the audience about the case descriptors. Our Black patient was a taxi driver and the white patient was a CEO. And so, are we reinforcing stereotypes, things like that? That was intentional. The cases were created that way intentionally because we wanted to highlight the potential for implicit bias. And, like Naomi was discussing, assuming that because of the patient's profession or line of work that we're making assumptions about what therapy is appropriate for them, and highlighting that as a disparity and how we have to look beyond that. And so I just wanted to address that comment. And then I'd like to ask the first question to Naomi. You presented data from the Get with the Guidelines AFib study, and one of the staggering statistics from that study was that Black patients had a higher risk of stroke even when they got discharged on the best therapy that we could possibly get them, which was a DOAC, or first-line therapy for AFib. So why is this, and what was the proposed reason for this disparity?
So thank you for the question. The first thing that I wanted to mention is that, as we highlighted as a part of the presentation, the AFib trials, the DOAC trials, only included less than 2% of Black patients. So we truly do not know the true impact on this patient population. We don't really have enough data to ensure that this is the best medication in underrepresented groups. But this observation does pose an area of opportunity for future research. The researchers believe that this may be related to post-discharge adherence rates and stroke risk factors in African Americans. So if you remember this, the stroke risk factors tend to be higher in African Americans, and we don't know if this is disproportionately impacting their higher risk of stroke, even when discharged on a direct-acting oral anticoagulant. This was the C section of that ABC pathway. It's really important for us to focus on controlling those comorbidities and cardiovascular risk factors as well.
Sara, you're muted.
Sorry. I think it really highlights the importance of follow-up, right? And not letting anyone fall through the cracks, regardless of their racial group or racial identity. So Naomi, as a follow-up question to that, then what can health systems, what can we do to begin to approach this issue, to bring more equity to these underserved patients?
So I don't want to minimize the issue here and act like we can just solve it with a simple 3-step solution. But I do think that we need to acknowledge the issue, recognize that healthcare disparities exist, implicit bias exists, and let's talk about it. Let's talk about what we can do about it. We can form a committee of like-minded individuals, just like we did with AC Forum, to explore further, to try to ascertain exactly what the issue is at our particular institution. You could consider conducting patient surveys. You could consider pulling data in your patient population to figure out exactly what the problem is in our specific region, at our specific institution. And then you can attempt to begin to take action steps. And that's where we were talking about the call to action slide. Focus on updating some policies, develop some partnerships, have some provider training, and focused efforts on diversifying the workforce and addressing the specific items that were identified in the initial investigation.
Thanks, Naomi. One question I have for you, Julie, is, as part of this, effort and movement to make change to resolve disparities, what organizations, can people connect with or reach out to help with addressing these? And how could they potentially get more involved?
Sure. Thank you, Sara, for that question, for sure, and for really giving me the opportunity to give a little more in-depth information regarding intersocietal collaboration. I kind of figured this would likely be a topic for discussion during the questions section. So I did write down some of the organizations that were specifically discussed within the Thomas et al. Paper. So one of the organizations is the Heart Rhythm Society. It is an international nonprofit organization, and it was founded back in 1979. Its mission was really to improve the care of all patients by promoting research, education, optimal healthcare policies and standards. It does have a worldwide reach, so it's pursuing the diversity, equity, and inclusion in all organizational endeavors and initiatives. Another couple of organizations that are collaborating together are the American Heart Association and the American College of Cardiology. And they're working together to have some coexisting programmatic activities, and they have very strong leadership commitment so that they are able to promote these missions in order to address the diversity, equity, and inclusion within their workforce and the workforce in general, within the educational sphere, research, within racial and ethnic communities, and then also within all of their organizational structure too. Also mentioned within that paper was the Association of Black Cardiologists. And again, I think it's really important to bring this group up because they have been at the forefront since 1974. And their focus is on Black individuals and the underserved who are burdened by cardiovascular disease in general. I also wanted to mention the Alliance of Multicultural Physicians, which is simply referred to as the Alliance, but it is a collaboration of 5 different national organizations, and they came together wanting to collaborate with others to build a diverse workforce and to develop appropriate educational materials also. And even though these are a few that I'm mentioning here, we know that there are many organizations. They may be even organizations that we belong to now, or even potentially our own companies that we work for are incorporating DEI into their missions. I really wanted to share a personal story, if that's okay, in regards to how I was able to seek out an opportunity to increase my involvement into DEI and health disparity research. And so I had gotten an email from the AC Forum, like many of us get, to sign up for one of their upcoming webinars. And I reviewed it and quickly signed up. It was the one that was back from March 2021. It was a call to action, structural racism as a fundamental driver of health disparities, a presidential advisory from the American Heart Association. I sat through the entire presentation, and then, you know, the discussion afterwards with the panel of speakers was just so moving that I really just kind of felt this fire in my belly and knew that I had a passion, this passion for collaborating and working with others to really advocate for the underserved populations. So what I did was I did look up one of the presenters from that webinar, Dr. Paul Walker, and I reached out to him via email directly. Not sure if that was absolutely the most appropriate way to go about it, but I just knew I wanted to be involved in however I could. And he was working with ASHP on some practical steps to implementing these changes they were discussing. And so when I reached out to him, he had a wonderful response within his email. And he did clearly state that they were in the end of their completion of this task force initiative. But he said he knew of an organization that was looking for new committee members, and he recommended the AC Forum Idea Initiative. So he sent along the contact for me to reach out, and I did, and was warmly welcomed, and I was able to join onto the committee and actively participate now. And I also say this right now with a kind of selfishly, because I want to put in a plug for our truly amazing Idea Initiative. We are looking for committee members to join. We have lots that we are working on and would love, love, love to share in our work. So please reach out if you are at all interested. So sorry, that was kind of long-winded.
But I don't think any of us could have said it better, Julie. That was just a wonderful, personal story of how it's a real possibility for people to reach out and engage. So I thank you for being willing to share that and encouraging others to do so as well. We've been very grateful and privileged to have Julie as part of this initiative. So Naomi, I'm going to pitch the next question over to you. You mentioned in your part of the presentation about social determinants of health as potential barriers. So tell us a little bit more about the resources that exist to address those social determinants of health once they've been identified, and how do we actually go about using that?
Okay, so thank you, Sara. Maybe we can pull up the resource now and show you guys what it looks like. The Social Determinants of Health Rapid Resource, which I mentioned is available at the AC Forum Center of Excellence Resource Center. There we go. Okay, thank you. And so the first page just provides a little bit of background on the various social determinants of health that could be at play impacting a patient's care. And then on the second page, you can actually use this as a quick reference to take into the room with you, or if you're addressing a patient telephonically, you can use it as an easy, quick checklist to address each specific item. It has, I think we have 6 different items listed, but each has a recommended action for that specific item. So I mentioned trying to, break it down into smaller pieces and focus on that specific item at play. So for example, for access issues, it provides suggestions on exploring telehealth or home INR monitoring, maybe introducing the patient to mail order options. And then for food insecurity, you could refer the patient to a caseworker who can connect the patient to local resources. So that's an example of how you could use the checklist and begin to enact change and operationalize this material.
And so there have been several questions, Naomi, in the from the audience in the Q&A box about like can you go into a little bit more detail about some strategies to overcome some of these, social determinants of health obstacles? They're numerous. So can you give us some ideas or strategies of how to talk with the patients or get them to the right resources?
Sure. Yeah. And I don't want to make light of this. It can be extreme. You could have one patient who has all 6 different issues at play, but you can try to break it down into small pieces to eat the elephant one bite at a time. Focus on working to address that specific item one at a time. So with a patient who has barriers affecting their ability to be adherent to a medication, it doesn't make sense to continue to stress on them. You have to take this medication, you have to take this medication without addressing the underlying issue. So if they have financial limitations, for example, you want to try to get them connected with a copay card or get them on a medication that's covered by their benefits. Once you can address that specific underlying issue, then you can begin to address the adherence, and then that in turn affects outcomes. So I'd say to try to break it down into small pieces. Take a look at the resource ahead of time before you're in the room with the patient. You don't need to memorize it, but it is pretty intuitive. And then in that way, you can quickly be able to go through the checklist and incorporate it into your normal conversation with the patient. I mean, normally when you're conversing with the patient about how are you doing with your medications, have you had any issues with your medications at all that have impacted your ability to take them twice a day? Sometimes it can be difficult for someone to remember to take the medication twice a day. And therefore, maybe once you build trust with that patient, they might be honest with you about, well, actually, it's way too expensive. I can't afford it. So I only take it once a day. And then you can talk further. That opens up the door for you to talk further. I know some providers break this up into different visits. So they may not address the entire checklist in the initial 15-minute visit, but they know that they're going to speak with the patient again 1 month from now. So they do what they can in the initial visit, and then they save the other items for the next visit. In this way, I think by breaking it down and building trust with the patient, maybe they will open up to you and you can begin to address each item one at a time.
I think that's a very practical approach because it does feel big and overwhelming when you look at everything all together. But if you just start with the absolute basic barrier and then you can kind of work your way in. And as you said, I think building trust is a big factor to engage, all patients, but especially those who maybe have some inherent mistrust of the healthcare system. Now, Julie, I know that you and your institution have created this as a possibility and incorporated this into your practice. So tell us a little bit about that.
Yes. So thank you, Naomi, for going into some of those examples and really I think the big picture takeaway is, like you said, to take it into smaller chunks. But what we did at the Cleveland Clinic is we actually started a pilot program within our main campus anticoagulation clinic. And the reason we targeted this specific clinic out of the other 10 clinics that we could have chosen that are scattered in the Northeast Ohio area was because the main campus was historically having a lower time in therapeutic range percentage as a whole clinic. And so we really wanted to take a deeper dive into this and examine why this was occurring at this specific location. And did it have anything to do really with these social determinants of health? And so we ran a report to capture these patients that had a time in therapeutic range of less than 40% is what we decided to start with. And we contacted these patients to set up their next appointment for a 60-minute appointment. So we did extend the appointment length so that we could have that ample time to be able to re-educate the patient on warfarin just in general and a lot of the other pieces that go along with it. We also took a look at these patients prior to their visit to assess first and foremost if a DOAC would be more appropriate for them. When they would come in then for their appointment, we would sit down with them. We would explain why this appointment is longer than their usual appointment. And we would kind of just really set forth what we were hoping to get out of it in terms of, we would discuss with them why their INR is so important and what even does time and therapeutic range mean and why that is so important for them in order to have better outcomes. And then we embedded a screening tool, very similar to what Naomi just went over with us. We really used the rapid resource tool kind of as a skeleton to put this together. And we put it right straight within our note template. And so as we were sitting there with the patient and going through all of this re-education for them, we also then were able to use this tool to screen for some social determinants of health. And what we also did prior to setting up this pilot was we connected with our social work team and even our nutritional team too, to see if it would be possible if we did flag a patient to have some sort of issue with paying for their medication or even transportation issues, etc. Could we reach out for a social work consult? So we were able to set up and provide those services also. So the screening tool, I don't want to go too in depth because Naomi hit most of the ones that we particularly hit too. But basically we ask the questions. We have 3 columns set up within this tool. The first column is the question that we ask the patient when they're sitting with us. The second column is if the patient answered yes, what are some things we can do? And so it gives the pharmacist in our case, or the provider, some examples of how they can, help this patient. And then the final column is where we, as the provider, will put in what intervention we took so that we could have all of that for data later on. We are actually now in our second phase of this pilot program because we want to increase the volume so that we do have better data. But even with that first phase of the pilot, we were able to see that there was a significant increase in the time and therapeutic range for all of the patients as a whole. And many of our interventions really surrounded more education than anything. We, found that the patients really didn't have the best understanding of vitamin K and how the diet can affect the INR. So just being able to spend some more intentional time with them is what we found to be one of the biggest factors. It's not a perfect process yet. We're still continually tweaking parts of it. But what it has allowed us to do is really look at the patient as a whole. It has allowed us to stop and walk in their shoes, feel empathy for the patient, that possibly, maybe they can't get a ride to their appointment, or they just cannot even obtain their medication this month. So it's helped us to coordinate care better and collaborate with others within our organization in the best interest of the patient.
And so, Julie, so thank you so much for sharing that, because I think that is huge, because so many of us don't even know where to start. And so that is a great example of how you guys just took it and kind of built little by little, and acknowledging, hey, this is a work in progress, but you are making progress. Now everyone has different practice models and things like that. So can you describe really quick how long your normal visits are versus how long these extended visits are? And also if you think that this applies to, or could be applied to, like a telephone-based model.
Sure. Of course. Yes. So our kind of clinic structure is for new patients that are newly referred to us. They do get an initial 30-minute education appointment. Then all of our established patients after that, it is a 15-minute appointment. So recognizing that that is a very short, time frame to get all of this information in, we were able to, go to our leadership and kind of show them that we think with this tool and this type of appointment restructure to be able to give the patient some more education will really benefit the patient. So that is our hope throughout the different phases of this pilot, is to be able to really gather that data that potentially these longer appointments could really benefit. Now, after that initial 60-minute appointment, we do leave it up to the pharmacist. They have the autonomy to decide whether the next follow-up visit should be a longer visit or should it just go right back to the 15-minute visit. As far as the telephone-based appointments, we definitely think it could be, converted to a telephonic type of appointment. However, what we see is more engagement when we have that patient right in front of us and can, have that face-to-face interaction.
Okay. Well, thank you for that. And then also one last question, like, is there a way that you can, is your tool like in a form that you could make it available for others to see as an example?
Definitely. Yes. It's just a smart phrase that we use within Epic, but it can definitely be shared for sure.
All right. So we will work on getting that out as an example of excellence. Julie, thank you so much. And I'll turn it over to Ashley for our final announcements.
Yes, thank you so much, Sarah, and thank you, Julie and Naomi, as well, for this wonderful conversation and insightful presentation today. As always, our webinar is being recorded and will be available on our website shortly. We are also pleased to offer Enduring Ethics CE for this webinar. The link is available in the chat, and it'll also be posted on our website along with the recording. Just a few quick announcements before we close. If you're interested in learning more about the IDEA initiative or programs and want to be involved in the committee, we're always looking for new members and new ideas. You can email info@acforum.org to learn more about how you can be involved. We have just 30 days left until our national conference. It's a great opportunity to engage with faculty experts, so we invite you to join us for this weekend in San Francisco this April. There's over 85 abstract posters, 16 hours of CME, and it's an in-person event not to be missed. Rates do go up this Thursday, March 2nd, so if you're considering it, definitely act fast. And if you are already planning on joining us, note that the deadline to reserve our room block at the conference hotel is March 10th. Lastly, I'd like to thank our corporate sponsors who helped to support this webinar program. And thank you all for sharing this hour with us, and we hope that you have a wonderful rest of your day.